Drugs with hepatotoxic effects. I think this mind map is very great. At least it pinpoints various aspects of these hepatotoxic effects of some drugs. So we will try and use this to brainstorm and bring back every knowledge that we know about these drugs with hepatotoxic effects. The drug-induced liver toxicity is a common cause of liver injury, and it accounts for approximately half of the cases of acute liver failure and mimics all forms of acute and chronic liver disease. And more than 900 drugs have been implicated in causing liver injury. So it's the most common reason for a drug to be withdrawn from the market, and most often these drugs tend to cause acute hepatitis, cholestasis, and a combination of these conditions. So the clinical picture often resembles acute viral hepatitis with jaundice, malaise, anorexia, nausea, and abdominal pain. So the pathogenesis of drug-induced liver injury usually involves the participation of a toxic drug or a metabolite, and this either elicits an immune response or directly affects the biochemistry of the cell. And in each case, the resultant cell death leads to the clinical manifestation of hepatitis. So, more on the pathogenesis, the drug metabolites can be free radicals that promote a variety of chemical reactions, and this could result in depletion of reduced glutathione and or induced lipid peroxidation. So all of these have subsequent direct effects on organelles such as the mitochondria, endoplasmic reticulum, or the nucleus. And in addition to this, sensitization to liver-specific cytokines can occur. Yeah, it can also occur, thereby causing cytokine-induced hepatotoxicity. So alternate, um, you know, the parent drug or the relative metabolites may alter. Yeah, they may alter the liver proteins such as the cytochrome P450 enzymes, leading to an immune-mediated injury. And the risk of drug-induced hepatotoxicity involves a complex interplay of factors. So these include chemical properties of a drug, concomitant use of drugs or alcohol, age, genetic factors, and underlying diseases. And the most documented risk factors are concomitant drug use and underlying diseases too. So risk factors, there is evidence of an increase in drug-induced liver disease among patients with HIV, hepatitis C, and the also genetic factors often include genes that control drug metabolism and transport, and certain drugs will produce predictable liver damage in a majority of cases. Others will cause liver injury only rarely and unpredictably too. So there is a whole spectrum varying between these extremes. And the mechanism of drug-induced liver damage, in some cases, the mechanism may involve parent compound, and in others, a metabolite. So direct cytotoxicity is known to be a most common cause of liver damage. And the other mechanisms include, they may include interference with bilirubin uptake, excretion and conjugation, cholestatic injury, fatty liver, and steatosis, and with chronic hepatitis too. So with direct cytotoxic injury, direct damage to hepatic parenchyma may be caused by a number of drugs. So acetaminophen causes predictable centrilobular hepatic necrosis, and doses of 10 grams may lead to liver damage, and doses higher than 15 grams may be sufficient for fatal hepatic damage. Cytotoxic injury with regards to liver damage may be detected by raised serum transaminases like AST, ALT, and bilirubin levels may be only moderately elevated, and this liver damage is due to direct cytotoxic effects of a metabolite of acetaminophen. Acetaminophen or paracetamol is metabolized via three pathways, two of which are conjugation reactions. I think this one we explained it in the other tutorial. So a minor pathway catalyzed by the microsomal enzymes yields a reactive metabolite called NAPK, N-acetyl para or P-benzoquinonimine. Yeah, so following normal doses, this metabolite undergoes glutathione conjugation and is excreted as N-acetylcysteine. It's a derivative. Yeah, so the N-acetylcysteine is a derivative and it's passed through the urine through excretion too. Alright, so during high doses of acetaminophen, the glutathione levels are depleted, and the active metabolite that reacts covalently with cellular macromolecules causes damage, and the mechanism by which this binding causes cellular damage remains unknown. For halothane, a general anesthetic is also known to cause direct hepatic injury, and the majority of cases of halothane-induced hepatic injury, more than 80% occur in patients after more than one exposure, and this halothane-induced liver injury often presents as a syndrome. So a syndrome may include fever and myalgia, but arthralgia and rash are rare, and it has been suggested that there are two forms of hepatic injury from halothane. There is mild form with slightly raised serum transaminases and perhaps mild necrosis. Then there are also more serious form which leads to massive hepatic necrosis and death in some cases. And actually, this is suggested that the later severe form has an immunological basis, whereas the more mild form is due to direct cytotoxicity. Right. So with interference with bilirubin uptake, conjugation, and excretion, a number of drugs interfere with bilirubin transport, and this leads to elevated plasma bilirubin. That's why we say hyperbilirubinemia. The rifampicin, for example, is used in the treatment of tuberculosis. It inhibits both the uptake and excretion of bilirubin in a dose-related manner. Interference with bilirubin transport. This gives rise to elevated plasma levels of both the conjugated and unconjugated bilirubin. And other effects of rifampicin include interference with DNA synthesis and the ability to induce hepatic microsomal enzymes. So these two effects, however, are not thought to be responsible for hepatic damage. Cholestatic injury too could also occur. That's the third point. And remember that chlorpromazine, which is a tranquilizer, is an important cause of drug-induced jaundice, and the incidence is estimated at between 0.5 and 1% of recipients of therapeutic doses. And jaundice commonly develops after 3 weeks of therapy, which often the development of fever, itching, abdominal pain, nausea, and anorexia occurs. Another cholestatic injury is it's similar to extrahepatic obstructive jaundice with elevated serum cholesterol and alkaline phosphatase. It's more than 4 times normal. So the lesion is generally one of cholestasis, particularly in cerebellar regions, and may also be scattered areas of focal necrosis. Chlorpromazine clearly has a number of effects on membranes and on transport mechanisms, and probable that its primary site of injury is the bile ductus, and the actual mechanism, however, remains unclear. So steroids with alkyl group at C17, such as methyl testosterone, may also be hepatotoxic, and this normally a cholestatic injury, generally without parenchymal damage. The degree of injury and rate of development seem to be dependent on dose, and the tetracycline occasionally causes not cholestatic injury but fatty liver steatosis. So it causes fatty liver after large IV doses, and this toxic effect is really um, it really occurs, like it's rare after oral doses. Yeah, in IV doses it's usually occurs large IV doses or a prolonged period of time, but for oral doses, just minimal one, and occurs more commonly with females than males. So biochemically, the changes may only be slight, and with moderate elevations of aspartate transaminase. Fatty liver, bilirubin levels are usually only moderately elevated. This toxic effect of tetracycline is direct, predictable, and dose dependent. Okay, so let's move on to chronic active hepatitis and subacute necrosis. You know, the anti-tubercular drug isoniazid can cause hepatic dysfunction in a significant proportion of recipients, and the syndrome of isoniazid-induced hepatic damage is similar to viral hepatitis. So usually AST and ALT levels are elevated up to 10 to 20 times normal. That's serious. Yeah, so histologically, necrosis ranges from focal to massive, and cholestasis may at times be very significant. And there are a number of predisposing factors for isoniazid-induced hepatic damage and persistent liver dysfunction, such as alcoholic cirrhosis, which increases susceptibility. So studies reveal that Asian males are more susceptible to isoniazid-induced hepatic diseases than white males, and also black males are markedly less susceptible. An important factor for isoniazid-induced hepatic damage is the acetylator phenotype. So isoniazid is actually metabolized by several routes, acetylation being a major role, and there are well-known genetic and ethnic effects with this reaction. So human subjects may be divided into rapid and low acetylators, and you know, rapid acetylators, that's what the problem is, they'll convert it to the active metabolite, which is highly toxic. There's not acetylators, or it will take a time before you build up the metabolized drug from the parent drug, which will lead to the hepatotoxicity. So the mechanism of isoniazid-induced hepatotoxic or hepatic damage involves production of a toxic metabolite, and data suggests that the rapid acetylation may be a predisposing factor, as this would produce more of a metabolite, which is the acetyl isoniazid, and hence more acetyl hydrazine, which is more, and these are very toxic too. So these metabolites are extremely hepatotoxic, causing centrilobular hepatic necrosis, and the relatively high incidence of hepatic dysfunction associated with isoniazid has curtailed its prophylactic use. Alright, so that's it for drugs with hepatotoxic effects.